Thanks everyone for joining us. We're very pleased to be joined by Dr. Aniket Saoji. He completed a bachelor's and master's degree in speech language pathology and audiology at the All India Institute of Speech and Hearing, and he then went on to complete a Ph.D. in hearing sciences at the Psychoacoustic Laboratory in the Center for Hearing and Deafness at the State University of New York. He's now a clinical audiologist, the director of the cochlear implant program, and chair of the Division of Audiology in the Department of Otorhinolaryngology, Head and Neck Surgery at Mayo Clinic in Rochester, Minnesota. So thanks so much for joining us.
Good morning, everyone. My name is Aniket Saoji. I would like to thank everybody for giving me an opportunity to present here this morning, and thank you all for coming to my talk. Today, I'll be talking about well, I got my title wrong because I'm using a slide from one of my previous talks, but basically I wanted to talk about monitoring the auditory nerve structure versus function during vestibular schwannoma resection, and we would monitor that using cochlear implants. Here is a slide on my disclosures. I'm a consultant or I have research support here from Advanced Bionics, Cochlear Americas, and Envoy Medical. So coming to vestibular schwannoma, I think vestibular schwannoma is nothing new for the audience on this talk. There is now about 1 in 500% prevalence on vestibular schwannoma. And I think that's simply because we have now more awareness and better tools to kind of image and diagnose vestibular schwannoma. And cochlear implantation in vestibular schwannoma can be tricky, especially for Medicare patients, because the Medicare criteria says that patients with retrocochlear pathology should not be implanted. So it's whether sporadic or NF2. If the patients are having Medicare as their insurance, then that falls into, I think, a gray area. So I've heard descriptions like oh, it's vestibular schwannoma and not a tumor of the auditory nerve. So I don't know if that will fly, but that's what we have been talking about here. And for quite some time, MRI compatibility was an issue because these patients may need MRI every 1 year or every 2 or 3 years. And so having a compatible magnet was really important. But I think all the three manufacturers have now done a good job of having MRI compatible magnets. So one of the things that we have been doing at Mayo, and I've been working with Dr. Carlson, Dr. Driscoll, Dr. Neff, and Dr. Donhofer now. We have 4 neurotologists and our neurotology fellows and residents here. We have been working on placing the implant during surgery, mostly in translabyrinthine, translab CI kind of tumor resection cases. And once the implant is placed, we can then measure electrical compound action potential or neural response telemetry, auditory brainstem response, the electrically evoked auditory brainstem response, and then I'll talk in detail about the electrical stapedial reflex. And we have been using all three methods to kind of monitor the auditory nerve integrity during tumor resection. So one of the two most commonly used measurements for monitoring the auditory nerve during vestibular schwannoma resection is one is the electrical compound action potential and the other is the electrical auditory brainstem response. The electrical compound action potential is also called as NRT, neural response telemetry by Cochlear, neural response imaging by Advanced Bionics, and ART by Medel. In the literature, it is also referred to as CNAP, cochlear nerve action potential. So they all basically means that we present either an acoustic stimulus or an electric stimulus, and the spiral ganglion generates potential that is then recorded, and that is the source of this electrical compound action potential. Now, while using a cochlear implant, the way this is measured is we present a single biphasic pulse and on, let's say, one of the electrodes, and then we use a couple of electrodes away, another electrode in the cochlea to record that potential. So it's the stimulus is presented inside the cochlea and the recording is made inside the cochlea. And that's how This is typically measured through the cochlear implant. It's a very robust response. It's about 200, 300 microvolts. So it's a large response like the one shown here on the right side. It is very easy to measure. It is very well established. It is kind of a black and white response. When it's present, and when it's absent. Very rarely we'll see that technical parameters influence an eye measurement. It is possible, but it's not often that things in the OR will interfere with this measurement. One of the things that we did with the AB device as well as with the cochlear device was to measure streaming NRT. So it takes about 2 seconds to measure, get a good NRT response, because we present a biphasic pulse average, then present another biphasic pulse average, and we keep doing this for 2 seconds. And here comes a nice, beautiful N1P1 response. And it takes about 2 seconds. So if we keep running this in the loop, then you push the button once and it is measuring the response. This is the most commonly measured response during vestibular schwannoma resection, yeah, especially the electrically evoked compound action potential to monitor the auditory nerve. Here is a data on 5 patients, which I just finished plotting this figure yesterday, and I included it here. So this is patient 1, patient 2, patient 3, patient 4, and patient 5. And these are their intraoperative responses. They're pretty rock solid response, really good reliability, and everything is really good. And then post-operatively, at the time of activation, or maybe 1 month activation, the electrical compound action potential is still preserved, and it looks really nice, all 5 of them. So this patient here, patient 1, does not hear any sound through their cochlear implant. Patient 2 does not hear any sound through the cochlear implant. Patient 3 does not hear any sound through their cochlear implant, even at the highest level of stimulation. Uh, Patient 4 hears sound through the cochlear implant for 1 second, and after that, the nerve adapts so quickly that the sound that the patient hears quickly disappears, becomes inaudible. And then this patient here hears sound, but it's basically pings, 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 pings. So again, sound looks like the sound is adapting so quickly and is unable to build any loudness. So this, I think, very clearly shows that the most preferred method of monitoring the auditory nerve is not really a reliable method to know whether the nerve is intact or not during tumor resection. And that's probably because the tumor is located near the pontine angle. I'm an audiologist, so you'll have to bear with my poor anatomy here. But the spiral ganglion are very close to the cochlea, and the tumor probably is not having any impact on the spiral ganglion. So an electrical stimulus will generate an action potential, which will be recorded. But whatever happens with the tumor or the auditory nerve beyond the point of the spiral ganglion are not going to have any impact on the electrical compound action potential. And that is why that is probably why the electrical compound action potential is really not a very reliable method to to monitor auditory nerve during vestibular schwannoma resection. One of the questions that I've been asked is it because we stimulate and we record in the cochlea, that we are recording it from this side? What if we could stimulate in the cochlea, but record on the other side of the tumor? I've seen a presentation by one of the neurosurgeons from Japan where they actually put an electrode in the foramen luschka and measure it from there. And so that's, I think, a very good question, is if the nerve is dissected during tumor resection, will electrical compound action potential still be present if the recording electrode was not intracochlear but somewhere extracochlear, like in the foramen luschka? I don't know the answer, but I can try to predict the answer based on the EABR measurements. So let's come to EABR measurements here. EABR measurements are the another reliable method I think we use to say whether the nerve is intact or not. There is nothing new here. This EABR is very similar to the uh, to the acoustic ABR that we measure. The one thing to remember is wave 5 is a little bit quicker, like it's around 4 milliseconds, 3.54 milliseconds or 4.5 milliseconds, as opposed to somewhere between 5 to 6 milliseconds. And that's because we are basically bypassing the external ear, the middle ear, and the cochlea, and stimulating the nerve directly. So that's basically like a 1 millisecond kind of a delay, 1 to 2 millisecond kind of a delay that is introduced by the external middle ear and the traveling wave of the cochlea. And so we are bypassing all of that, and that's why this peak happens sooner. Sometimes there are large artifacts here at the early time frame when we are measuring the brainstem response, and that's why we generally don't see the wave 1 or wave 2. We kind of see the wave 3 here somewhere and wave 5. So now one thing again about the intraoperative monitoring of with using EABR is that we present a single biphasic pulse. It generates a response. Then we present another biphasic pulse. It generates a response. We average a few hundreds or thousands of those, and that is how we measure an ABR. So again, it's a single pulse response. And so I believe that even if we have some fibers remaining that can conduct electrical signal, it will generate a response. The electrical EABR is very, very low in amplitude, like 1, 2, maybe 5 microvolt. So it's a very small response. That is why we need hundreds and thousands of averages, and that is why it's such a delayed response and delayed measurement. And so whenever we want to know quickly whether the nerve is intact or not, it takes like at least a minute or so or 2 minutes to kind of get this response. And we have to stop everything. You cannot use a bipolar cautery. We cannot use a press probe while making these measurements. So for all the patients that we have monitored by, I think, 15 patients so far, and we have always gotten an EABR measurement, maybe except one patient who we thought was a vestibular schwannoma, but actually had an hemangioma, and we'll talk about that later. But whenever the EABR is present, we rarely lose the EABR during surgery. It is almost always present at the time of closing, if it is present in the beginning. And so I believe it's probably just because, if there are some fibers of the auditory nerve remaining that are intact and that can conduct electrical signal, it will generate an action potential, but we wouldn't know if the nerve is fully functional or not. And so what do I mean by that? Oops, I need to put the speaker off. Okay. So coming to electrical stapedial reflex, and why did we introduce this into our test battery in the OR? And that is because we found that NRT was not really helping, or I should say electrical compound action potential was not a very reliable measure. The EABR was always present at the time of closing, but still the patient did not hear sound through the cochlear implant. And so we said we need something that is quick, that is more black and white, that is reliable. And so we introduced the electrical stapedial tendon contraction. Now, there is one big difference in the stimulus that is used to measure electrical compound action potential, EABR, and the stapedial reflex. For the stapedial reflex, we present a pulse strain, and the pulse strain is roughly 500 milliseconds or half a second in duration. And we present 2 or 3 of these. So half a second stimulus on, half a second stimulus off, then again half a second stimulus on and then off, and that's how we do it. And and if the pulse strain generate is loud enough, then it ends up producing a stapedial tendon movement, which the surgeon is observing through the microscope. So here is the stapedial tendon, and you can see it contract when this loud sound is presented. The nice thing about this is when the loud sound is presented, it interferes with the EMG monitors, so we actually know that the sound was delivered and our connection was intact. And then the surgeon is observing this through the scope, and it's very black and white. The slight disadvantage to this is every time you want to monitor the stapedial reflex, you have to move the microscope and focus it on the stapedial tendon, and so move it away from the field of the tumor and focus on the middle ear. And also, so you cannot pack the middle ear as well as you would want to, because you still need to see the tendon and hopefully and make sure that the packing does not interfere with the tendon. So, so what we have seen is that the reflex is present in the beginning during the surgery, and then at some point it's possible that we may lose the reflex. And so what could be potentially happening? So we lose the reflex, but the EABR and the NRT is still present, and we'll come to that. So one of the important properties of this stimulus pulse train is that each pulse here is contributing to the loudness that is generated by this stimulus. And as long as the auditory nerve can accumulate sound over time, that's the temporal integration properties. And we used to, in the previous days, used to use the reflex decay test to detect tumors and tumors in the past. And so this property of temporal integration is at play here. So if the nerve is affected by a little bit, whether it's the blood supply or something like that, I think very quickly the auditory nerve may lose the property to accumulate sound over time, and the reflex disappears halfway during the surgery. The nerve is still intact and is able to kind of conduct electricity, but it is not able to accumulate sound over time, and that's why the reflex goes away. And I'll talk about this more in a one particular case later on. So we have been using all these three techniques, NRT, EABR, and stapedial reflex to monitor during vestibular schwannoma resection. We have 12 cases on this slide here. I think right now our number is somewhere around 14 or 15 cases. 9 patients have a sporadic vestibular schwannoma. 1 patient has an F2 associated vestibular schwannoma, and 1 patient had an internal auditory canal hemangioma. And in this patient, we did not get anything. We did not get a NRT. We did not get EABR. We did not get stapedial tendon contraction. So here is an example of a patient where we got the stapedial reflex during at the beginning when they placed the CI, and then once they open the dura and start taking the tumor out, we lost the stapedial reflex, and the patient does not get any auditory sensation. The NRT and EABR were present throughout the surgery, but we lost the reflex. This is the second case where we lost the reflex halfway through the surgery. And this is the patient. This patient 4 here is the patient where uh, if we, so what normally what we do is we present 3 beeps, beep 1, beep 2, and beep 3, and then ask the patient to judge the loudness of those beeps, and that's how we map the cochlear implant. So we present 3 beeps to the patient. The beep 1 is comfortably loud, beep 2 is almost inaudible, and beep 3 is inaudible. Like the patient wouldn't be able to tell that there is a beep 3. And so this is a very clear indication that the auditory nerve is intact. It is able to conduct electricity, but is not able to build loudness over time. And so this patient with that 1 to 2 seconds of electrical stimulation that the patient hears, it gets some level of tinnitus suppression, although that can be questionable at times, but certainly does not hear any sound after the first 1 or 2 seconds when we switch the implant on. Uh, so, so here is another case where we lost stapedial reflex during surgery, and the patient does not hear auditory sensation. Um, so actually, this case here, uh, with a 2.8 centimeter tumor in the opposite ear, this is the same patient, the bilateral patient. This patient actually has an ABI and the CI in the same ear. And that is because we were monitoring the CI, we were monitoring stuff with the CI, and we preserved everything till the end, but we couldn't guarantee that the patient is actually going to hear any sound in the implanted ear. So they went ahead and placed an ABI in that ear. And so ABI and CI sitting next side by side in the same ear. And so both the devices stim fairly well. With the CI, the patient performs at about 80% at plus 10 dB signal to noise ratio with AZ biosentences. Uh, so it's like a star performer does really well, and the ABI gives all sorts of non-auditory sensation and at very soft levels and is of no use. And the other ear has a CI that does not produce any sound. So had they taken that CI out and put an ABI in, because it's such a large tumor, and we believe that in large tumors the nerve is almost always dissected, this patient probably would not have done or not have heard at all, because the ABIs are basically the sleeper devices, is a sleeper device. So something I think is really interesting here is, if ESRT is present, it gives us good confidence that the patient is likely to hear the sound after surgery through the CI. Now, one thing I would like to say about ESRT is, yeah, in my opinion, I think we are all gonna differ a little bit on this. So I'll give you my audiologist opinion here. As soon as the CI is placed, it is very important to measure the ESRT. And I'm pretty sure Dr. Carlson might disagree and all of that. But the reason being, as the dura is open and as the vestibular is open, additional pathways of current returning back to the implant open up, and that could potentially directly stimulate the facial motor neuron. And I think it's very important to isolate direct facial motor neuron stimulation from the actual stapedial reflex arc, where the current goes to the cochlear nerve and then stimulates the facial motor neuron and the tendon. Because once the vestibule is open, it can cause facial stim. So we see that once the vestibule is open and we go high enough in current levels, the whole face contracts on the microscope along with the tendon. So at that point, it is hard to know whether it's the direct facial stimulation that is generating the tendon contraction, or is it going through the cochlear nerve? And so that's one thing that needs to be kept in mind. And the second thing is, sometimes when the reflex is absent, we want to make sure that the facial motor neuron is okay. So what Dr. Carlson will do once in a while is take the PRAS probe and go with a 1 milliamp current and stimulate it near the facial motor neuron. And if near the tendon, and if the tendon contracts, then we know that at least the facial motor neuron is okay and the tendon contracts. So a couple of things we are still learning about the ESRT as to how do we exactly manage this. We have now started looking at the threshold, and what we are seeing that as the surgery goes on, that more and more current is needed to elicit the stapedial reflex. So that tells us that something is happening with the nerve. But we have still found that when the reflex is present at the end, it may be a weaker reflex, or we need more current to elicit a reflex. It is still the patient hears some sound through the implant. And and we have started looking into the current requirements for patients with translap CI, and we generally see that 2 to 3 times more current is needed to achieve comfortably loud sensation for patients with translap CIs as compared to a normal CI patient. So I think everything is telling us that the ability of the nerve to conduct electrical stimulus and accumulate sound over time may be compromised due to the trauma. And I think that is probably a better indication of the auditory nerve function than what EABR and ECAP actually shows us. Here is the data on the CNC scores, tumor size on the x-axis, CNC and AZ bio % correct on the y-axis. The 4 red dots are the patients in whom the reflex was lost halfway or at some point during the surgery. The patients don't hear any sound, obviously don't get any speech perception, so their score is 0%. And then in patient where the reflex was present at the time of closing, they hear sound through the CI and show variable amount of benefit through their cochlear implant. So discussion, NRT and EABR use multiple response averages. They are evoked by a single biphasic pulse. So they probably look into the auditory nerve structure and integrate and the connection of the auditory nerve. Whereas ESRT employs a pulse train and maybe tapping into the temporal integration properties of the auditory nerve. One thing what is also very interesting is that in ABI patients, even if we have some ABI patients who have normal hearing in the opposite ear. And by stimulating the ABI, we want to see if we can elicit a contralateral stapedial reflex using the emittance bridge or middle ear analyzer. And I don't think I've been able to elicit a middle ear response by any amount of stimulation through the ABI. So again, the ABI may simply not, and we have seen this, that the growth of loudness in the ABI through an ABI is pretty compromised. So again, the ABI may not be able to tap into the auditory nerves, temporal integration properties, and that's why the outcome might be limited. So everything is pointing that ESRT might be looking at something different than NRT and EABR. And then in patients where we lose the stapedius reflex at sometime during the surgery, those patients either hear sound that quickly adapts or don't hear any sound at all. Again, showing that the nerve might be intact, but the adaptation is so quick that they're not able to make any use of that electrical stimulation. Thank you.